All right. So I'm going to talk to you all today about pelvic floor physical therapy and how this pelvic health can be incorporated into your basic orthopedic clientele or sports clientele. So I will present a brief case on a gal who's a CrossFitter. But before we get started, I'm a orthopedic physical therapist in New Braunfels, Texas, for Texas Physical Therapy Specialist. I came here from Georgia, from the state of Georgia, and I did my residency with Dr. Allison Ellis as my mentor. I did a pelvic health rotation, and I found that a just pure pelvic health rotation was missing a lot of the orthopedic regional interdependence influence that I think we need to get all of our patients better with pelvic health conditions or chronic low back pain. So without further ado, let me share my screen. Okay. Emily, can you give me a yay or nay that you can see my screen right there?
Not right now.
Okay. Well,
Katie, I also have the presentation up on my desktop if you would like me to share my screen and I can just click along for you.
Yeah, that would be great.
Perfect.
I'll cue you for next.
Awesome.
All right. Thank you.
You're welcome.
Okay, go ahead and click the next button for me. So when we're at Texas Physical Therapy Specialists, our markets, our South market, where I am in, and our North market, where AJ or Anthony is in, we do continuing education rounds every month for our therapists. So this is an example of a recent Con Ed in-house round that I gave to our practicing clinicians who are specialists so that they can kind of streamline and hone in on their pelvic floor therapy assessment and treatment. Go ahead and click next. Okay, so our case, we've got a 36-year-old female who participates in CrossFit. She had right-sided low back pain around that local PSIS area. Pulling, achy, difficulty with sitting, sit to stand, squatting, deadlifting, and picking up items from the floor. She felt better when she used heat or just didn't do those activities, and she really wanted to return to her exercise routine. Her body chart was otherwise clear, no red flags. Emily, go ahead and click next for me. So what do? Well, we have some subjective screening questions that I created for our clinicians, and we needed to streamline some of the questioning. So in addition to our typical body chart, I always ask all of my patients, especially those with low back pain, do you cough, sneeze, do you leak when you cough, sneeze, or perform your CrossFit activities? And or do you have difficulty initiating stream of urine? I find that sometimes it can be hard to normalize these questions, but they are important, and the more that you do practice them in your clinical practice and intake, they become routine, and you can make the patient feel like it's, just a normal question, like, do you have shoulder pain? Emily, go ahead and click next for me. Anatomy and physiology. So depending on where you are in your schooling, either curriculum wise or school itself, you may or may not have high didactic influence on pelvic floor therapy and knowledge. So just for those of you that haven't gotten here yet or need a little refresher, here's our anatomy and physiology. So for the sports person, abdominal core work, diaphragm, low back strength, and the pelvic floor are all going to work together for all of our lifters. Go ahead and click next for me. There we go. And as you all have learned as you go through your orthopedic coursework, we do have this concept of regional interdependence. So you will be looking at muscles like the piriformis, the obturator internus, your transverse abdominis core. Can you fire your glutes? Can you use your back extensors appropriately? Okay, go ahead and click next for me. So here's some fun facts. We're going to pause on this screen for a second. There's the good old saying for pelvic floor innervation, that S1, S2, S3, S4, keep pee and poo off the floor. That's great. So it does show that we do need to look at the SI joint, the lower lumbar sacral plexus. Most of our pelvic floor is 70% fast twitch fiber, 30% slow twitch fiber. So you are going to be looking at coordination for both of those muscle groups, for a superficial layer. And then the deep layer that really supports us all day long is going to be a 70% slow twitch distribution and a 30% fast twitch distribution. So what I typically find in my CrossFitters and lifters is that we have a slower recruitment of that fast twitch muscle group that you need when you create that intra-abdominal pressure to lift. I also find this in patients with low back pain. So 60%, the stat is 60% of women with low back pain also have pelvic floor dysfunction. Okay, there haven't been that many studies done on men, but I do use these concepts all the time with my male lifters. Emily will go ahead and go to the next slide. As you get into your orthopedic coursework, you guys should be learning about the TBC treatment-based classification review update, where we have motor control deficit category. I'd like to postulate that we need to put the pelvic floor in that motor control deficit category as well for all of our low back pain patients. Emily, go ahead and go to the next slide. Okay. When you have a patient with low back pain or an athlete with low back pain, we do want to do a comprehensive screen. So that includes our special test, observing Gower's sign, prone instability testing, which you have learned or will learn depending on your didactic coursework curriculum. Emily, go ahead and go to the next screen for me. Okay. So in my when I'm doing my in-house presentations, this is where we would pause and really look at assessing our own pelvic floor strength and endurance so we can learn how to coach our patients. Since this is virtual, we're not going to do this portion. I am, though, going to have all of you guys on the call do a interactive pelvic floor motion assessment in just a minute. So Emily, if you can go to the next screen for me. And then the next one. We'll skip this one for now. And then we'll go to the next screen. And then the next one, and we're going to come back to these in a second. Okay, so if you guys are in a place where you can all stand up, I want you to all stand up. Hey, AJ, will you do this with me? You don't have to turn your mic on, you're good. All right, squatting is a basic exercise, right? So what I want you all to do is squeeze the muscles around your anal sphincter, like you're trying not to pass gas in church. We've all been there. Squeeze those muscles, continue breathing normally, and I want you to go ahead and go into a squat, keeping that squeeze. AJ, go ahead, he's going to demo it. All the way down, get into a low squat, keep that hold, and come back up. Keep that hold, and then relax. AJ, thumbs up if you are able to hold your pelvic floor contraction through the whole entire squat. You could? Okay, good. Kind of halfway. Did you lose it at the top of the squat? The bottom of the squat? Okay. That's pretty common. So I'm sure some of you have also lost your pelvic floor contraction towards the bottom of the squat. And the reason is, if you go back a couple of slides, Emily. Okay. Right there. Our pelvic floor needs to turn on and off. So if you look at the star number 1, pelvic floor muscles, like anything else, needs to isometrically turn on, turn off. If you had trouble with that, you may have had difficulty navigating activation with the global strength training of a squat, okay? A lot of our patients will have that. Emily, go ahead and go one slide closer or one slide forward. So if a patient has difficulty, like AJ did, holding pelvic floor at the bottom of the squat, I need to take him back a notch, and we need to look at diaphragm, TRA, and then his 1 rep max hold of a pelvic floor contraction in supine, as well as his ability to contract quickly in supine. Okay. So this is just an example of how this particular CrossFit patient presented. She was only able to hold a 6-second hold in supine, no load, no squatting, and she could only do 4 quick contractions in a 10-second time window, which has been a standardized assessment for pelvic floor. So I would not be training my CrossFitter right now with heavy loaded squats until I could get her pelvic floor under control and coordinated. Emily, go ahead and go forward a slide for me. Okay. So goal writing, in 2 to 4 weeks, I want her to be able to do a 10-second hold 10 times in supine. And I want to see her coordination and quick contractions get a little bit faster before I start to marry her pelvic floor into squatting mechanics so that she stops, her low back pain decreases over time. Emily, go ahead and go forward again and again. This CrossFitter also had difficulty with an overhead squat press. So again, I could have you guys, we're not going to do it, but I could have you guys stand up, arms overhead, pelvic floor contraction, squat, push back up with a barbell. Okay. It's much harder than it looks when you're trying to do it. Okay, go ahead and go forward again, Emily. And one more time. Okay. And this is just a friendly reminder to my colleagues that we're treating all the muscles all of the time. So I may be having this patient do clams. I may be having her do isolated bridge work without pelvic floor contraction. And I might be having her do core bracing, just like you would any other patient with low back pain. Go ahead and go forward again, Emily. And then one more time. Okay. So that's just a brief presentation on how we do teach with in-house. Some of our more specialized points of treatment, like pelvic floor therapy or lymphatics is another one that we'll go through, or sport-specific exercises. So pelvic health, what I want my students to take away if they're with me for a rotation is that, one, it's not scary. We need to demystify it. I want my students to get comfortable assessing the pelvic floor externally over clothes to see if the patients can turn on, turn off their pelvic floor. And I want my students to be able to assess pelvic floor with all low back pain and hip patients. That should always be a competing hypothesis for them. If you have somebody come in who's in that motor control category of the treatment-based classification, I do want all of my students to also check the pelvic floor. No ifs, ands, or buts. Okay. AJ, do you guys typically incorporate some of your higher level athletes with pelvic floor training as well?
Yeah, like you said earlier, I won't put somebody, under a bar, especially when coming out post rehab or post surgery, post op, until they can control that, deep core TA type muscles. Because I do not want to send them to like you or somebody, later down the line because I missed it, right?
Right.
And it puts them at risk for any sort of like low back injury too.
Agreed. Yeah. And I think, just having the two of us on this call it just shows that, I do have a background in pelvic health, but Dr. Warner does not have a background in pelvic health. He is he's a sports specialist, does a lot of orthopedic work, and he's able to recognize that pelvic floor has its place, and a very important place in our athletic population. And I do think that as our school programs across the country get stronger and better, I am seeing more and more pelvic health show up in the curriculum. I am involved with Baylor University, so we do a really good job, a solid job there. I got it in my program. I know the University of Alabama is starting to incorporate it, and some of you guys in other places in Texas may also, and across the country, may be also having pelvic floor exposure in your curriculum. So knowing that pelvic health is not necessarily just, you know, in a room with a pelvic floor specialist and a bunch of devices and biofeedback. It is applicable as an orthopedic approach.
100%. I agree.